Hello, my name is David Gable. I'd like to talk to you about keratoconus and why it was felt necessary to start a charity to encourage people with this condition to meet and share experiences. Keratoconus is an eye condition that affects the cornea, the transparent front of the eye. Here we see a normal cornea and one with keratoconus. Our charity is called the Keratoconus Self-Help and Support Association. It is exactly what it says, a self-help organisation run by a small group of individuals from all walks of life. Our common bond is that we all have the condition, and we all give our time freely. The charity has no paid staff. None of us are medically trained, but what we have is a wealth of experience living with keratoconus. We call it KC for short. KC affects nearly 1 in 2,000, although with growing awareness and modern technology, more people are being correctly identified and the incidence is growing. KC is believed to result from a combination of genetic, environmental and hormonal factors. This means that although a person may be susceptible, it will not develop without other factors coming into play. One of the contributory factors is eye rubbing. So if you see a child really digging into their eyes, try to find a way to stop them. There is much research into the causes of KC, but as yet we do not have the answers. KC usually makes its appearance in the teens and early 20s. It affects us at a crucial time, just when we are starting to make our way in life. While it is scary to be diagnosed with a condition no one has ever heard of, there are lots of options these days. It is important to see a good optician, one that is equipped with modern technology. Not all opticians will recognise KC and may just think you have a very bad astigmatism. That is why it's very important to get a referral to a hospital eye clinic where KC can be diagnosed and treatment started early. The name comes from Greek and Latin words meaning cone-shaped cornea. It is caused by the cornea thinning and bulging, as you can see here. Some people will only ever get it mildly, and it might not progress much at all. Others will require contact lenses. In the past, around 20% of people with KC ended up needing a corneal transplant. Fortunately, with early intervention, fewer patients are progressing to this stage. The early intervention I alluded to is a procedure called Corneal Cross-Linking, which you will hear referred to as CXL. This is a process where the vitamin riboflavin in the form of drops are put into the eye, which is then exposed to ultraviolet light. This causes new bonds to form across adjacent collagen strands in the cornea. Effectively, this ages and stiffens the cornea, with the intention of stopping the progression of the disease. The procedure was developed in Dresden in 1998 and gradually adopted around the world. This has transformed the prospects for people being diagnosed now. They may not need contact lenses if their vision could be corrected with glasses before they had cross-linking. If they do need contact lenses, it is likely that it will be easier to fit the lenses and the prescription will stay stable, no changes every few months. If you go to the Moorfields website, you can see their success rates and safety record after performing over 4,500 procedures. This slide illustrates how the light rays coming into the eye are scattered by the irregular shape of the cornea, causing them to hit different points on the retina at the back of the eye, and therefore cannot be brought to a single point of focus. In practice, someone with KC sees multiple blurred images of everything, all overlapping to different degrees and in different directions and with different strengths. What we see depends on the geometry of the cornea, and this is why everyone with KC is different, and it is impossible to give a single image to represent every case. This results in a ghosted image, as you see in this photograph. There is nothing a spectacle lens can do to improve the situation. Whatever the spectacle lens does to improve the incoming rays, they are always scattered by the misshapen cornea, which is the next thing they hit. and the cornea provides 80% of the focusing power of the eye. When asked the question, "Can you read this letter?" a person with KC can answer yes, but there is a lot of difference between the image on the left and the one they see on the right. Imagine if you put several letters together in a word where all the secondary images overlap. You can read the word, but it is slow going. It would be very easy for a teacher to underestimate the capability of such a slow reader. It is just as bad when you go out into the street, and even worse when the lights come on. This slide illustrates the progression of the disease. The top left-hand corner shows a room with chairs before the condition starts, and then subsequent pictures show how the image gets distorted if the disease progresses. You can see here what happens when you put a contact lens over the misshapen cornea. It smooths out the surface so that all the various points of light hit the retina at the same spot, i.e. properly focused, producing a much clearer image. Contact lenses are our saviour, but they can be extremely painful if the fit isn't good. There have been many developments to improve the tolerance, starting with gas-permeable material in the mid-70s. There are special soft lenses for KC and hybrid lenses with a rigid middle for vision and soft outer for comfort. Scleral lenses have improved with modern materials and offer a solution in that the lens is much larger and sits on the white of the eye, relieving the pressure on the centre. There are also semi or mini sclerals, which sit just outside the iris ring and rest on the white of the eye. They also help with the problem of irritation on the eyelid. Some people find that placing a rigid lens on top of a soft lens helps. This is known as piggybacking. All these solutions have benefits and disadvantages. When it becomes difficult to tolerate contact lenses, or they can no longer correct the vision, then surgery in the form of a corneal transplant becomes an option. Surgical techniques are improving all the time, and less cornea material is being removed. To ease the demand on eye banks, Newcastle University is developing 3D printing of corneas, incorporating the patient's own cells. From its start in 1991, when a small group of people met to share experiences, the KC group has grown, and it now distributes a twice-yearly newsletter by post or email to nearly 3,000 people. It holds regular meetings and a national conference every other year. In 2014, I came across one of the KC group's leaflets and made contact. Much later, it occurred to me that since first experiencing problems in 1969, that phone call 45 years later, I had not spoken to a single person who had the condition. Life with keratoconus is full of compromises, choices and decisions. There is no definitive answer. Different contact lenses have benefits and disadvantages. Surgery has risks, and the vision after a corneal transplant is not as predictable as we would like. You may still need contact lenses, or, as in my case, glasses. Steroid drops can solve one problem, but hasten cataracts. It's all a question of balancing needs, risks, tolerance and comfort. Having said all this, the future is getting brighter every year. We are hopeful that many young people will be able to avoid the problems I have covered by undergoing cross-linking. Most KC stabilises by age 40. This is why our charity exists, to give patients access to information to help them make these difficult decisions and offer support when they need it. The following slide will show our contact details. Please phone our helpline and visit our forum and website to get more information or copies of our leaflets on work, education and other topics. Thank you for watching. Please support us.